Hello everyone. I'd first like to thank the SAGE's leadership and staff for their monumental efforts in changing the entire SAGE's meeting to this virtual format and still deliver to everyone, hopefully, what will be a great educational opportunity. I'd also like to say thank you to Dr. Kitan and Dr. Goldblatt for the opportunity to share some of our work on synthetic mesh in a contaminated field. These are my disclosures, none of which have any bearing on today's talk. One of the most feared complications of complex abdominal wall reconstruction is the risk of mesh infection. I'm sure we've all had some experience with these complex situations. Following a complex or contaminated ventral hernia repair, the risk of mesh infection may often lead to the need for mesh removal and then the invariable hernia recurrence, and ultimately an even more complicated recurrent hernia repair. I would argue, however, that not all mesh infection requires the same treatment, and not all mesh will necessarily behave the same in a high risk or contaminated situation. There's several key factors that we need to consider when deciding what type of mesh to use in a potentially contaminated operation. First, is all contamination created equally? Is the small enterotomy made during adhesiolysis the same as an intracutaneous fistula? What is the primary purpose and goal of the operation? Are you there primarily for a colostomy reversal, or was this an intended hernia repair all along? Does the mesh characteristics determine the clinical outcome? Does the mesh location in the abdominal wall determine the clinical outcome? And then what are the consequences of placing this permanent synthetic mesh at the time of this operation? What is the risk of infection? What are the chances you'll be able to salvage that mesh? And then what are the repair options available to you in terms of both technique as well as staging options? First, defining contamination. We're all familiar with the CDC guidelines for classification of a clean, contaminated, and dirty or infected wounds. But I would argue that this doesn't necessarily capture the full range of contamination in some complex hernia repair. This can range from chronic open wounds to intracutaneous fistulas to those requiring an ostomy reversal or some other planned bowel resection to grossly contaminated and infected mesh. Looking at some of these pre-existing cases, you often are able to come up with a very good plan for the patient leading into the operation and give a proper informed consent of what to expect out of the operation and what the primary goals of the operation may be. In contrast, an enterotomy made during the course of a planned elective ventral hernia repair may actually change the course of that operation even more than a known pre-existing contaminant. We next have to consider some of the potential risk factors for infection or contamination. This was popularized by the Ventral Hernia Working Group some years ago, looking at obesity, diabetes, other comorbidities, and the complexity of the hernia repair as possible sources of contamination or possible increased risk of wound complications following an operation. It should be noted that this is not necessarily the same thing as contamination, just a potential for a higher risk of wound complications. One of the most important considerations when faced with one of these potentially contaminated hernia repairs is to define clearly for the patient what the primary purpose of the operation is. Is this a colostomy reversal? Is this a cancer resection? Is this an intracutaneous fistula takedown? If that's the case, I will typically tell the patient that that is the primary focus of the operation, to get rid of their fistula, to remove their cancer, to get rid of their colostomy. The hernia repair then becomes secondary. It is important, but it is not the primary focus of the operation. Any parts of the primary operation that don't go as planned, for example, an anastomotic leak after a colorectal anastomosis, then the hernia repair can easily be converted to a staged operation or possibly change the mesh selection. So, what is the optimal mesh for use in the setting of contamination? There are a lot of possible options out there now. There's the classic permanent synthetic meshes comprised of PTFE, polypropylene, or polyester with a whole variety of constructs within each category. There are absorbable synthetic meshes that typically have a life of somewhere between 6 and 18 months. We have biologic meshes from various sources, as well as some hybrid meshes still available on the market. Well, per FDA guidelines, there are actually no meshes that are currently indicated for use in a contaminated field. We then have to rely on our knowledge of how each of these mesh materials and constructs might behave in the clinical setting to best make the decision for our patient. What we really need to know is the biocompatibility of that mesh, or its ability to perform with an appropriate host response in any given application. Understanding how mesh characteristics impact this biocompatibility is key. Probably the most important characteristic is the pore size, or the space between the mesh fibers themselves. Probably second most important is the overall construct. Is this a multifilament or a monofilament material? Studies looking at bacterial adherence to various mesh types highlight some of these differences. You can see in the top left here that a smaller pore monofilament polypropylene mesh has significantly lower bacterial adherence than a laminar microporous PTFE structure. You can see in the figure in the lower right that as the pore size increases, the bacterial adherence significantly decreases, with the exception of one mesh that has a very large pore size but is also a multifilament mesh. We see similar trends when we look at the clearance of bacteria after an inoculation. The small pore monofilament meshes tend to behave much better than a laminar microporous structure. Even among biologic meshes, there are differences in how these will behave in the setting of contamination, though admittedly we don't know much about why these behave differently based on their physical construct. We also see differences in biofilm formation among different meshes, with a monofilament polypropylene mesh actually behaving much better than a biologic in experimental models. Much of these benefits of the pore size may have to do with the simple fact that there is greater ability for host response and tissue ingrowth between the interstices of a larger pore mesh, which allows for greater immune response, neovascularization, and granulation. All this is fine and good in the lab, of course, but what we really want to know is how these meshes behave in the clinical setting, because that's where we all actually practice. I won't try to cover the entirety of the literature on this subject. Most of you already know that there's a lot of literature out there, most of which is not terribly high-level data. So I really want to just cover a couple of highlights and then review some of our experience with synthetic mesh in a contaminated field. The RICH trial was one of the earlier studies evaluating porcine acellular dermis in the setting of complex abdominal wall reconstruction. With this study of 24-month follow-up, wound infection still occurred at a fairly high rate, with total wound events of 66%, as well as a 28% hernia recurrence rate at 2 years. More recent data comparing multiple biologic mesh types demonstrates their hernia recurrence rate to be between 15 and 60%, with significant variation across different mesh types, but with a non-cross-linked porcine acellular dermis performing the best. The newer class of absorbable synthetic meshes have shown some promise as well. The COBRA trial was a prospective multicenter study evaluating outcomes using a polyglycolide and trimethylcarbonate copolymer. With 24-month follow-up, wound events occurred in 28% of patients, with a recurrence rate of 17%. The more recently introduced poly-4-hydroxybutyrate mesh has shown some promise as well. This study of 120 patients in a multicenter prospective trial demonstrated a 9% rate of SSI and 9% hernia recurrence rate at 18 months. It should be noted that the absorption profile of this mesh is actually 18 months, so longer-term data is needed to assess the true hernia recurrence rate. One problem with all of these biologic and bioabsorbable constructs is that we don't really know how they behave in vivo. This is a video of a piece of non-cross-linked porcine acellular dermis that I pulled out of a patient 2 years post-op, and as you can see, it really looks just like a piece of PTFE mesh. Nowitzki performed a study showing the lack of biologic activity in many of these biologic meshes did not show any significant neovascularity or tissue ingrowth. Unfortunately, high-level comparative data is not readily available for biologic versus synthetic mesh. In this study by John Fisher, we can see that there is no significant difference in wound infection between synthetic and biologic mesh in high-risk hernia repair patients, but there is a significant difference in hernia recurrence, with biologic recurrence being much higher than synthetic mesh. It's also important to consider the significantly higher cost of using a biologic mesh in these patients. At our institution, we recently reviewed our outcomes of synthetic mesh in a contaminated field. We reviewed 541 patients with clean, contaminated, or dirty wounds, most of which were repaired with permanent synthetic mesh, and also compared this to those repaired primarily, those repaired with an absorbable synthetic mesh, and those repaired with a biologic mesh. The demographic and comorbidity profiles of these groups was similar with the exception of COPD, which was significantly higher in the absorbable synthetic and biologic mesh groups. There is likely some selection bias, however, as we did have a higher rate of dirty wounds in the absorbable synthetic and biologic mesh groups. Hernia size was no different between groups. There were some minor variations in technique, with a higher incidence of intraperitoneal mesh placement for the biologic mesh group in particular. We actually found that the lowest rate of SSI was in the permanent synthetic mesh group, with the highest rate of SSI in the biologic mesh group. To account for the differences that we saw between groups, a multivariate analysis for the risk factors for developing an SSI was performed. We found that COPD and presence of a dirty or infected wound were the only factors that indicated a higher risk of surgical site infection. The choice of permanent synthetic, absorbable synthetic, or biologic mesh did not impact the risk of SSI. We also found that the lowest risk of hernia recurrence was when we used permanent synthetic mesh. This was significantly better than either absorbable synthetic or biologic mesh, though as you can see there are some differences in length of follow-up that may contribute to this finding. Again, to account for some of the differences between our groups, we ran a multivariate analysis for recurrence, and again we found that COPD was a significant predictor of hernia recurrence, as was the development of a postoperative SSI. We found that permanent synthetic mesh was significantly protective against the risk of developing a hernia recurrence. The next key consideration when considering placing mesh in a contaminated hernia repair is the position in the abdominal wall, be that in an onlay position above the anterior fascia, a sublay repair in either the retromuscular or preperitoneal position, or an underlay repair in an intraperitoneal position. Previous meta-analysis comparing sublay retromuscular repair to an onlay repair with mesh show a significant benefit of the sublay position in terms of both SSI as well as hernia recurrence. Another recent analysis confirmed that sublay has the highest probability of being the best repair in terms of both hernia recurrence as well as SSI compared to the onlay, inlay, or underlay techniques. Despite having some clinical data to support the use of permanent synthetic mesh in a contaminated field, as well as some of the basic science studies that I've reviewed, and conflicting data with the biologic and bioabsorbable meshes, we still have to consider what the outcome of a permanent synthetic mesh in a contaminated field in the event of a surgical site infection, as we could be looking at that ultimate mesh removal. So it's really important to consider what the actual impact of a mesh infection is going to be. What happens when you've performed a colostomy reversal and placed a large retromuscular polypropylene mesh, and 5 days post-op you see this picture of a bilious drain and a serous drain from an anastomotic leak? What happens when you have a previous intraperitoneal mesh that is now infected after a subsequent abdominal operation? And this is really the crux of our argument in favor of using permanent synthetic mesh. It has to be the right mesh and be used in the right position. Looking back at our contaminated hernia repair study, we found that we did have some mesh-related complications and some mesh removals were required, though we actually had just as many biologic and absorbable synthetic meshes removed as we did permanent synthetic mesh. Importantly, many of these mesh removals were not actually directly related to the mesh itself and were results of additional intra-abdominal pathology such as a colostomy disruption or a missed enterotomy, something that required an emergency laparotomy, re-entry into the abdominal cavity, and almost by necessity removal of the mesh to simply address the underlying pathology. When a patient is sick in that scenario, you typically don't want to invest the extra time to replace the mesh. And finally, we need to know how various meshes will behave in the event of an ultimate infection, because this will still happen regardless of the type of mesh that you use in these complex situations. We reviewed our total experience of caring for patients with a mesh infection. We reviewed over 200 cases of mesh infection that we have cared for in our institution. Our primary outcome was evaluation of the factors that would affect the rate of mesh salvage. We evaluated based on position within the abdominal wall as well as various mesh characteristics, including the pore size, monofilament or multifilament nature of the mesh, etc. What we found is that when mesh was placed in an extraperitoneal position, either in an onlay, preperitoneal, or retromuscular position, and it was a large pore or macroporous monofilament polypropylene mesh salvage was possible in over 70% of cases. In contrast, when mesh was in an intraperitoneal position, it was rarely salvageable. Also, microporous mesh, multifilament mesh, laminar PTFE mesh, or composite meshes comprised of more than one type of mesh were almost universally unsalvageable and required complete explantation. So going back here, if we can arrest this cycle with mesh infection and not require mesh removal by proper mesh selection, then we do not have the inevitable hernia recurrence and the recurrent complex hernia that we have to now deal with. So ultimately, what is the verdict? Is synthetic mesh safe in a contaminated ventral hernia repair? I believe yes, if it is a properly selected case, properly selected mesh, and properly performed operation. Placement of a large pore monofilament mesh in an extraperitoneal position, probably ideally in the retromuscular plane, is perfectly appropriate for use in most contaminated ventral hernia repairs. There is adequate data out there at this point to suggest that this is safe, results in probably the lowest risk of hernia recurrence, and is salvageable in most cases. And it's also important to point out that the literature on absorbable synthetic or biologic mesh is not necessarily any more compelling than that for synthetic mesh in a contaminated setting. Most of the literature is limited to retrospective single center reviews, and there's very little comparative data out there and no significant prospective randomized control trials. There is one multi-center randomized control trial that is seeking to address this issue. Cleveland Clinic is the primary site for this, and we've been privileged to participate as well. We're evaluating the role of permanent synthetic mesh versus non-cross-linked porcine acellular dermis used in a retromuscular position for complex hernia repair in Class 2 or Class 3 ventral hernia repairs. Enrollment is completed for the study, and we are just waiting for 2-year follow-up to complete the study. Hopefully that will shed some light on this debate of permanent synthetic versus biologic mesh for these complex hernia repairs. I think it is still critical to remember the primary indication for the procedure. You do not necessarily have to perform the Cadillac hernia repair and abdominal wall reconstruction. If you're in a case that has a significant degree of contamination, or there are some other complications related to the primary objective of the operation, such as an anastomotic leak, some alternative to a definitive abdominal wall reconstruction should probably be considered. This could include a primary closure of the fascia with an expected hernia recurrence, but at least in this case you've not burned tendy bridges by performing any additional myofascial releases or introduced the potential complexity of previous mesh. You could also consider using an absorbable synthetic or biologic mesh in this instance. I think the literature certainly supports its use in some complex hernia repairs with acceptable outcomes. However, I do think that the cost of these meshes should be considered. Thank you all very much for your time, and I hope this was an instructional talk and a good primer for where to begin looking at how to use the proper mesh for your complex hernia patients. And again, a big thank you to SAGES and all the support staff for making this happen.